Hello everyone. Welcome you all to yet another episode of the IJA Authors Podcast. I'm your host, Dr. Gayatri Sasikumar, and I welcome all of you to a brand new year and a brand new episode. Wishing all our listeners a very happy new year, and I, on behalf of all members of the IJA podcast team, want to thank each and every one of you for giving all the love that you gave us the last year and hoping you continue to show us the love in the coming year. Now, as is the tradition, the January episode of the IJA, in the Indian Journal of Anaesthesia, focuses on one particular topic. And this issue focuses on systematic reviews and meta-analysis. So I'm very excited to bring you two brilliant authors and the articles that have been published in the issue today. And to start off with, I welcome Dr. Rakesh Garg, the editor-in-chief. Dr. Rakesh, welcome to the podcast and wish you a happy new year.
Thank you so much, ma'am, and wish you all and wish all the IJA readers a very happy academic new year. And I think a lot of academic fun will be coming through IJA, as was in 2024. Same will be in 2025. And thank you, our IJA podcast team, including Dr. Murli, Dr. Gayatri especially, for taking the wonderful academics into 2025 as well.
Thank you very much, Dr. Rakesh. Dr. Rakesh, since this is a issue focused on systematic reviews and meta-analysis, I'd like to begin with asking you a few questions. How do you decide when a systematic review is warranted versus when primary research is needed?
Right, this is an important aspect. When we talk about evidence-based medicine, we need some concrete conclusion from the research that we have. And as we have discussed in previous podcasts also, when we do a research, we include a sample size, we have some primary objective, and on those sample size, we try to conclude something. Now, if we do the extrapolation of the published research, we use the term external validity, that whether those results are applicable to the universe as such. In research parlance, we say universe, this means the whole population. And when we say whether it's applicability on, we usually decide something on an individual study. But if we conduct it multiple times at multiple places with various sample size, with various population, different population, with regards to the institute, with regards to the demography, with regards to the geography and so many other things, probably there will be something which differences will come. I'm sure, madam, you would have also seen that one study say this is definitely better, drug A is definitely better than drug B, technique A is better than drug B. Other study will say probably they appears equivocal, not much difference. Third study will say though they are statistically different, but clinically they are not different. So this means sometimes there would be some difference into the reporting of those studies. Now, it is not possible for us to do a study including a very large sample size from different areas. Though there is an option now people are starting doing multicentric studies, so that is taken care of. But that may not be always possible to include so many. So there is another statistical strategy with us where we try to pull the data of those studies. Nowadays, people are doing the individual data analysis also from multiple studies. So when we try to pull those data, probably we'll get some concluding statement for that primary objective. So if you see a couple of studies, sufficient number of studies, sufficient number of sample size, and when we're talking about in last podcast, you asked me a difficult question, Gayatri, as usual, that how is the sample size for a particular meta-analysis? I'm sure that you'll be asking this time also from either Dr. Abhijit or Dr. Shreya. So we talk about those sample size. So probably even in meta-analysis, we talk about those sample size. So we say that if a sufficient sample size has been included to make a concluding statement, then it's fine. On the other hand, if you have say 10 studies, 20 studies, and each study show a similar directionality and there is no confusion with sufficient sample size, and all 10-20 studies says that drug A is definitely better than drug B with regards to both clinical as well as statistical, probably it will not require a meta-analysis. But this usually does not happen. So that's why we go for meta-analysis for pulling off the data from each study and try to conclude something.
Okay. So another thing I wanted to ask you is, what are the most important things you think a beginner should keep in mind when, if they want to start doing a systematic review?
I think this is important, and recently the registration portal for the systematic review and meta-analysis have also put up an advisory, and they also have started rejecting it. The first and foremost thing is whether the similar systematic review and meta-analysis with same objectives has been published recently or not. They will not allow, and it is not also good to publish it. And recently, if you see, we have published one commentary, one editorial, and we'll be publishing in the next issue, February issue, where we have tried to identify this issue, the duplication of the systematic review meta-analysis in a short period. So this will be the editorial coming in February issue. I'll suggest that this question will be answered there itself. So if something has been published and it has been concluded well, and it is sufficient sample size, probably no further meta-analysis, or in fact no further research is required in that area for that objective. We can think of something else with the different objective. And secondly, when we do a systematic review and meta-analysis, so they had different corollaries. So again, we have published one editorial and one commentary in the past issues when not to do meta-analysis. Even if you see this issue of January, we have one systematic review where the authors have mentioned that meta-analysis is not required. So this will be based on when you do a initial search, you have an idea, do research, go on the various search engines like PubMed, Medline, Scopus, and also go into Prospero with whichever is the registration for the meta-analysis is being done, and try to identify whether either there is a conclusive statement which has come up, or there is already ongoing meta-analysis with similar objective. In those situations, probably it is not worth spending time and your manpower and infrastructure for doing on the same topic. So let those authors do it, and you can always critically appraise it. Sorry, you were asking something. I interrupted.
No, you answered my questions. I'm really sorry about that. So like you said, we register when we want to do a systematic review, we register in Prospero, and we also have the Prisma guidelines which help people to figure out what to do exactly when they're doing a systematic review. But can you are there any resources like books, articles, or online courses for someone who wants to learn more about systematic reviews and meta-analysis?
I do not know about a particular, in fact, I will not try to name even a particular person or a particular institute, but there are sufficient academic material which are available at various platforms which allows you to do it. And to begin with, it's always a good, as I mentioned previous about researches also, that from the beginning you can think of one good mentor for you. Because doing meta-analysis is more using a statistical tool. Any statistician can do it. It's not very tough thing. But the issue is when you start doing it, there are many nitty-gritties of meta-analysis which you need to understand. When to do meta-analysis, when not to do it. If you see the simple things, this is again a good narrative review in this issue. When we try to analyze them, we try to use various models. It would be a fixed model or a random model. It could be there would be a lot of heterogeneity in the data that we collect. So what should we use? Which model should we use? And how to adjust them, sensitivity analysis, meta-regressions, and then the trial sequential analysis. And more recently, we have one meta-analysis, which is a network meta-analysis. So there are very wide variations nowadays for meta-analysis also. And it is just not statistical thing. That is one aspect. Most of the statistics being done nowadays for meta-analysis, there are softwares available and it's easy. So we don't have to use calculators and all those things, which was earlier days, 20, 30 years back, and that's why it was difficult. But now we have good tools available, that is softwares available, You just need to extract data and put it. But then it is something like garbage in and garbage out. So if you don't apply the right things, it will give you whatever you want, but that is not right. And then it gets rejected and it's waste of time. So those basic things needs to be understood. And this issue has included certain narrative reviews also. So we have tried to incorporate certain aspects. It's a big topic, but we have taken basic aspects into the January issue of IJA. So I request everybody to go through it. It will help you to start doing meta-analysis. It will help you to understand meta-analysis, that what those so-called forestries and what so-called ROBs, and we put some small dots, traffic lights, small diamonds and all those things. So what they are and what they mean. So if we can go along, that's important. And the most important is, it is for all research, the interpretation. And this is, I think, I will put it again, I have put in the past also, that whatever comes on the output of a software is not equivalent to a clinical difference. So it's very clear that all statistical values may not warrant it to be equivalent to clinical significance. So here comes in the role of, again, our experience, our research, our finding of the findings from the various published material, and we have to interpret it. Say, for example, we have done, say, the intubation differences using direct laryngoscope versus video laryngoscope. We have certain studies, and if you just try to put it, I'm just giving a very hypothetical example. Say if it comes a significant difference, fine. But say if say p-value is 0.001, but one laryngoscope takes, say, 10 seconds, other takes 12 seconds for a normal airway with a normal lung, and p-value is 0.001, obviously statistically it will say that this laryngoscope is much better than this because p is 0.001. I mentioned p is not equivalent to clinical difference. It is something else. It is happening by chance. So here we say, though it will be a statistical significance, it may not be of any clinical relevance, because a difference of 10 seconds or a 12 seconds is not worth when we say the breath holding time is 20 seconds or 30 seconds for a normal patient. Same we can translate for even for the meta-analysis conclusion. So that difference should have some clinical significance. So here comes the role of your experience, your clinical interpretation, and you can always take help from the published literature, that what minimum clinical difference or minimum difference in the values would be of clinical significance. So this is how a beginner should think of. I am aware that some of us think that with the available of softwares, it's very easy, put there, get it out and it's done. But I'm sure that Abhijit and Shreya will agree to meet. The articles is to and fro sending back to them, multiple revisions, multiple things, because the reviewers will also try to interpret some good points of it, out of it. So once you publish, we want to minimize the limitation of that article, and we want to improve or show the author's hard work into a very focused output, which is written in the form of manuscript and published into a journal.
Okay, thank you very much, Dr. Rakesh. And it indeed is exciting to see that we have an issue focused on, I'm going to call it SRMA, Systematic Review and Meta-Analysis. It might be a little difficult to go through all of it because there might be, new things for beginners. So we are trying to see if we could have micro sessions in the podcast this month. Let's see how much we can do.
But Gayatri, one is clear that I know that you have read so much. It appears that you know SRMA much better than me, and you're the right person to write couple of SRMAs for IJA. I'm very sure about it, and I think looking at you, I can
I'm
see.
Just learning from everyone.
No, I think you should write a book on SRMA now.
So, Dr. Rakesh, we have these two wonderful articles that we have selected this month, and I am really happy to call the first author, Dr. Shreya Das Adhikari. She's an assistant professor at Kasturba Medical College, Manipal, and we're going to discuss her paper on effective intraoperative fluid volume on postoperative pulmonary complications with thoracic surgeries a systematic review and meta-analysis. I'd like to add that hers and her group's article, because I know that there's a huge contribution of a lot of people in this. Dr. Shreya, welcome to the podcast.
Thank you so much for inviting me for this podcast.
So, Dr. Shreya, your meta-analysis highlights that an increased intraoperative fluid volume is associated with a higher risk of postoperative pulmonary complications. And I'm going to call that PPCs now. So we've been talking about for a long time about goal-directed fluid management, restricted fluid management, liberal fluid management of thoracic surgery. Could you elaborate on how this finding might influence current clinical practice in thoracic surgery, especially in the absence of robust RCTs?
Certainly, this study highlights the importance of fluid restriction to minimize pulmonary complications after surgery. Clinicians should adopt conservative fluid strategies guided by real-time hemodynamic monitoring to avoid any excessive administration. However, when we did the systematic review, we realized that the RCT evidence is quite limited in this area. And the findings support this interim use of individualized fluid management protocols in thoracic surgeries, while we await a more robust evidence to be found. Currently, we could promote optimized fluid protocols rather, and we might want to see the type of patient and determine and protocolize we should not have we should have individualized protocol for these procedures rather than have a generalized protocol for all. We should also focus on enhanced preoperative risk assessment in terms of which patient might require a more conservative fluid therapy than another group of patients. Also, we should try to recognize the link between the PPC, as you say, and the fluid therapy with adequate postoperative monitoring as well and early interventions like respiratory support, like non-invasive ventilation. And
You talked about optimized fluid therapy. So, are there any specific thresholds or parameters you would recommend clinicians to consider when they're going to use definitions for restricted and optimized fluid therapies?
so, as we were going through the article, the studies included in this article, we saw that there is a vast difference in these definitions and these the thresholds that everybody has decided, which has been a sort of done according to their own experience. So this study, however, aligns with the growing preference for balanced fluid therapy over purely any liberal or restrictive strategies. Rather, parameters like 4 to 6 ml per kg per hour of intraoperative fluid administration has been shown to have a safe threshold. Other than that, there have been studies where they have done goal-directed fluid therapy using dynamic monitoring like stroke volume variation, and they can also further refine the decision making in these areas.
Okay, your study acknowledges that there are other risk factors for PPCs, such as smoking and pre-existing respiratory conditions. How did you account for these confounders in your analysis? And do you think these could have influenced the observed association between the fluid volume and PPCs?
Yes, we do acknowledge that there were a lot of confounding factors, especially smoking, pre-existing any respiratory condition, the ASA physical status of the patient, what were the indications for surgery, what type of surgery, was it an open surgery or was it a video-assisted thoracoscopic surgery, minimally invasive thoracoscopic surgeries. While all the studies identified potential confounders, but only few of them actually clearly addressed them in their analysis. Out of the 11, 3 did not tell us the clear strategy behind their how they address these confounding factors. These factors definitely amplified the observed results and the association between fluid volumes given and the postoperative pulmonary complications. Because there were patients who were inherently more vulnerable to fluid overload. So not all studies reported all the risk factors, so we could not actually account for all these influences completely. So yes, there's a lot of confounding factors which have not been completely addressed here.
Another thing that I noticed was that most of the studies that were included were observational studies, which by themselves have a high risk of bias. So, how confident are you in the causal relationship between, again, the fluid volume and efficacies, and what specific biases were most problematic in the included studies?
Causality, it is actually quite uncertain due to because we had to rely on observational data, which has its own inherent biases. Observational data have their inherent biases. We had a few retrospective studies as well, so that also contributed to the biases. Most of them were, some of them were confounded by indication and variability in defining the restrictive and liberal strategies. And there was also a selection bias in terms of why patients were given, some patients were given restrictive fluid while the others were given liberal fluid. These have not been addressed in the individual studies as much. Baseline variables, like as I mentioned, indications for surgery, type of resection, postoperative methods, intraoperative surgical techniques used. But despite this, the consistent association was there across all the studies that restrictive fluid strategy might help in preventing or reducing the postoperative complications, and then hence this strengthens the possibility of the relationship between PPCs and fluid volume. However, when it would have been great if we had RCTs where randomization would have taken care of all these confounders, but unfortunately we don't have proper RCTs which have evaluated the exact fluid who have been associated with pulmonary complications.
So, from what I understand, is it was because of the lack of robust RCTs that you were forced to take observational studies. And if when you are, confined to using observational studies, then how what can you do to account for these limitations that the observation studies come with?
So we generally use some checklists to address these issues, quality-related issues. Key issues included inadequate reporting of the exposure measurement, like in terms of what was the exact amount of fluid given per kg per hour, which we had to derive ourselves in terms of average duration of the study or average weight that the authors have described in their study. Other than that, failure to clearly define strategies for dealing with confounders, variability in outcome measures, and these limitations reduce the quality of the certainty of the conclusions. But yes, of course, we have to interpret these studies cautiously and need for further studies.
So some of the new names that I'm, learning, like you said, you use the for quality assessment. You use the Joanna Briggs Institute checklist, wasn't it?
Yes.
I also saw a software that you use called the Ryan software for duplicate removal and study screening. So could you share your experience with this tool and how did it streamline the process, and were there any limitations or challenges you encountered?
Ryan has been a very helpful tool in terms of it. It undergoes. There are a few steps where at first we have to upload all the studies that we have extracted from the databases, and it removes the duplicates, and it gives you a platform where you can easily do title and abstract screening, then full text screening, and then go decide which studies to be taken up. So it has been a very helpful tool. problems, there are other tools as well, like Ryan, that is one of the tools that commonly used. Other than, and I have not really faced major any issues other than maybe if citation search also could have been somehow added to this, or if you could have used some annotation on the PDF, if that could have been added to it, maybe. But I don't know how much that is possible.
So, we're talking about the Ryan, which was used to remove duplicate studies, right?
Yes.
But systematic reviews sometimes often face challenges of, with missing data. Sometimes you may miss out including certain studies which you may not get. So, how confident are you that your findings represent the full body of evidence?
So, as we had to do two meta-analysis because we had two different types of data. So each meta-analysis had only 5. One meta-analysis had 5, other had 6. Most of these missing data can be picked up with a funnel plot where we can go through the publication bias. But because it was less than 10, each meta-analysis had less than 10. So it was very difficult to assess the publication bias and hence the missing data. But because most of the studies had a trend towards a particular outcome, we were fairly okay with proceeding with the systematic review. But yes, I cannot, confidence in this remains moderate. And yes, we need more uniform data in future for probably we can have better analysis of this.
So, like Dr. Rakesh was mentioning initially when we began, he was talking about all the challenges that systematic reviews come with, right? So, what were the biggest obstacles you faced during this process and how did you overcome them?
Major obstacles were the heterogeneity in the study designs, actually. There were the various definitions of fluid strategies, how they had defined restrictive fluid or they had defined liberal fluid. And because of this, there was some inconsistent reporting. How we have mitigated these are we use checklists like Prisma. We use JBI checklist. Others might want to use Robbins or ROB for RCTs. And we also did trial sequence analysis to assess whether this was a robust evidence and further studies are required on this study.
And what about the communication between all the authors? Was it easy to communicate with everyone and get them on time to respond to all your emails and messages?
Everybody is in a different institute at different positions in their life. So I must say I was the one. We worked in a team. There was a methodologist who was doing the main statistical part, and so yes, I was the one actually who was dealing a bit more rather than others. So I should not probably comment.
Okay, Dr. Shreya, to conclude, I want to ask you one last question. You've emphasized the need for well-conducted RCTs to confirm your findings, right? What would, according to you, would be an ideal RCT on intraoperative fluid management in thoracic surgery, and what key outcomes should it focus on?
Yes, I have thought about this. An ideal RCT would have been preferably a multicentric study, and definitely a double-blind type of design, which will compare a standardized restrictive and liberal fluid strategy, where we have to come together and decide on one cutoff or a threshold value, and maybe use dynamic fluid or hemodynamic monitoring. And we should include a diverse patient population, not restricted to a certain group. That would get rid of a lot of confounders as well. And primary objectives would be the rate of pulmonary, postoperative pulmonary complications. And other secondary outcomes would be mortality, morbidity, and probably the cost effectiveness of the whole.
Thank you so much, Dr. Shreya, for joining us. It was lovely conversing with you.
I
And
think,
I hope we can get.
Dr. Gayatri, last question was important, which you asked, and this will be equally good to re-emphasize what Shreya has mentioned, that a good meta-analysis outcome will depend upon good RCTs which has been included, whatever the studies has been included. And I would suggest that all the researchers, especially who are learning, they should visit the website Equator Network, and it gives a lot of reporting guidelines. So those reporting guidelines are primarily while you're reporting it, but even when you are creating a protocol, you should go through them and try to include all the components of those reporting guidelines at each step of the study, so that each study is of good quality. And when we think of making a meta-analysis or publishing a meta-analysis, the quality of an individual study do matters, and that is sometimes do impact the meta-analysis outcomes. So it is again, you were talking about the various websites and the informations. I think Equator Network is a good website which gives a lot of information about various type of studies, in fact, and the components needs to be included.
Thank you very much. So the next paper that we are going to discuss is it was a systematic review done on the safety and efficacy of Remifentanil in patients undergoing bariatric and metabolic surgeries. And to discuss this article, I welcome Dr. Abhijit Nair, consultant anesthesiologist, the IBRA Hospital, Ministry of Health, Sultanate of Oman. Dr. Abhijit, welcome to the podcast.
Thank you so much. Thank you for the invite, Dr. Gayatri, Rakesh sir. It's an honor. I have been hearing this podcast from the time it has been initiated, and it's really nice to be here with my paper. Thank you for selecting it.
Dr. Abhijit, I've been waiting to get you to discuss more on systematic reviews and meta-analysis, because I've seen a few of your earlier systematic reviews published in the journal as well. So this time we're going to focus only on this article. So obese patients undergoing bariatric and metabolic surgeries, like we all know, obese patients come with a unique set of challenges, such as an increased risk of respiratory, depression, obstructive sleep apnea, and difficult airway management. Now, given these complexities, it is pertinent that we must, as anesthesiologists, must carefully select intraoperative analgesics to balance effective pain control with minimizing adverse effects. So could you talk to us about how Remifentanil, with its unique pharmacokinetic profile, fits into this context, and what prompted you to investigate its safety and efficacy in this group of patients?
Yeah, thank you for this question. Basically, let me start it from here. In my institute, we started bariatric surgeries maybe a year back, and initially we were doing some combinations of dexmedetomidine, lidocaine, etc. And then what happened, once in a while, we had problems in the recovery of the patient. We had to keep them for monitoring. Then once we used Remifentanil, and the effect was fantastic. We all know about Remifentanil. It's an ultra-short-acting opioid metabolized by non-specific esterases, and it has a very slow, small context sensitivity half time of 3 to 4 minutes. Even after an infusion of 6 to 8 hours also, it gets metabolized. So we saw that, and although I was very happy to see that, but then I just went to PubMed and wanted to see what is the evidence what is the status has it been used, and I just found a few papers towards Remi or equivocal, etc. And that's when I got an idea, why not embark on this. So that's how it started. Then the Prospero registration, and then the entire process started from that point of time.
Now, the next question that I'm going to ask you is on this similar lines that I asked Dr. Shreya. The inclusion criteria that your study focused on RCTs. Why did you choose to exclude observational studies, and how might their inclusion have impacted your findings? I'm asking this, it probably is a repeat question, but I think it's pertinent people understand how an observational study might, an RCT might be better in a systematic review than an observational study.
Yeah, most of the answers of this you have actually answered this in your previous interaction with Dr. Shreya. See, basically RCT are well planned, well organized prospective studies, and overall it is supposedly the risk of bias is less. Unfortunately, observational studies are good, but the problem with observational studies like case control, cross-sectional or cohort studies are that there is a high element of bias, and there are a lot of other problems in the sense the quality assessment is a problem. Statistical methods used are not standard. So what happens is if it is RCT, we know that the quality is better compared to this thing, your observational study. And along with that, there will be a lot of heterogeneity also in the observational studies compared to rather more than the otherwise well-designed RCT. And when we did the literature search, I have 7 RCTs in my hand, and our sample size total was more than 500. And actually, there were only 3 observational studies that I could get it, which I have actually cited but not taken into the meta-analysis. For obvious reasons, I didn't want to complicate the analysis. We do a meta-analysis with observational studies and RCTs. We use, like Dr. Shreya did, we use 2 different meta-analysis. And overall, as when we do something called as grade is like it is for the level of evidence. So the moment we put the type of study, it is either non-randomized or randomized. The moment we select non-randomized study, automatically you see at the end, the level of evidence is either low or very low to begin with. Then you add the other things, effect estimates and etc. All that you add later, and eventually it dilutes rather when you have a decent number of RCTs in your hand. So better stick to that. And this was the idea of selecting only RCTs for this meta-analysis.
Coming to your findings, were there any surprising or unexpected findings in your review, and how did you interpret and address them? And did it challenge any of your prior assumptions about remifentanil?
No, to be very frank, there wasn't any assumption to begin with, because it is like any other RCT that we do. If we have a prefixed idea in our mind, we tend to get biased at the time of our investigation. So no, it wasn't there. Although I was expecting certain things like probably the quality of recovery, etc. All this will be there. But unfortunately, these outcomes were actually not described in the outcomes in most of the studies. So the thing is, I was a little surprised, and I was very rightly corrected in my results from the IJA reviews that I got after my submission, that because the control group was extremely heterogeneous. See, for example, for 7 studies, 3 group had dexmedetomidine as the control, 2 group had sufentanil as the control, 1 group had dexmedetomidine with lidocaine as control, and 1 group had labetalol. Now, if you see, they are no way, except for sufentanil, they are no way similar to remifentanil. So, as such, regarding the dosing, regarding the analgesic efficacy, there is no way we can actually compare it in the sense the overall outcome, say for example the pain score and probably even the 24-hour opioid requirements. I wasn't expecting this, but yes, this was the eventual result, and this was the most important heterogeneity, including others. For example, the rescue analgesic was extremely inconsistent. So these were the things. Eventually it turned to a different direction, but eventually I was happy with the outcome of the paper after the multiple sessions of review, as Dr. Rakesh said. So we could stick to a path and come out with a rather equivocal conclusion. But this is fine. This is how the research is basically. So,
Dr. Abhijit, I want to ask you, you mentioned that a few studies did labetalol. So we were looking
yes,
at pain.
one study.
I was a little, taken aback when I said labetalol. I thought, I wanted to ask you if it was a printing error or something. So
No,
why
it wasn't.
labetalol?
Actually, in a few years back, regional anesthesia and pain medicine also had a good paper on analgesic efficacy of esmolol. It was like a bit difficult to digest that, but people have been using it, and here also they had used it as, it was not basically for used as a hemodynamic measure. They had used it as a control group, as an analgesic, like they used remifentanil. Probably the aim was to have the hemodynamics under control, probably, but they have used it as a control analgesic in the remifentanil group. So yes, this was an extreme deviation in the control group. So initially my idea was not to exclude this, but because it had many outcomes like similar to other outcomes, eventually I added this article also in the analysis.
And they also looked at the pain scores in those groups?
Yes.
Okay.
Yes.
All right. Now, your review concluded that the evidence neither supports nor refutes the use of remifentanil in bariatric surgeries. Were there any specific outcomes where remifentanil showed a clear advantage or disadvantage?
Disadvantage, yes. PONV was higher in the remifentanil group, surprisingly. Basically, again, I would like to mention here that the rescue analgesic used, which, because as we all know, remifentanil is a short-acting analgesic. Probably most of the patients, they required rescue analgesic in the immediate 15 minutes or 30 minutes or less than 1 hour. So the rescue analgesic was either morphine, it was paracetamol, it was pyritramide, which is again a synthetic opioid, it was pethidine. So these were the different varieties of medications that were used. So now we don't know basically in the remifentanil, and as we know, remifentanil is short acting, probably either of these, depending on the type of study patient had received, and invariably the PONV was more in the remifentanil group. But otherwise, 24-hour opioid consumption, pain scores and all, these were actually comparable in both the groups. So, but the thing is, I am talking from the meta-analysis point of view. Although we have reported meta-analysis in the as a supplementary file, we didn't include it, but we have just made a brief mention on this. The thing is, the grade that we did for these three outcomes, it was either low or it was very low. And this is the reason why there were no adverse events. Analgesia was comparable. So that is why I have the conclusion is neither. Currently, I don't promote remifentanil, although it is safe. There are meta-analysis on use of remifentanil for laparoscopic surgery per se, which also has bariatric surgeries, but this being typically bariatric surgery only. So this is why the sentence has been used like this.
Okay. So you just mentioned also that the quantitative meta-analysis was not feasible due to the lack of comparable data, right? So in cases where meta-analysis is not possible, what alternative methods or approaches do you recommend to synthesize evidence effectively?
See, one thing is very simple, that if you don't have enough data or rather enough studies for a particular outcome, in that case you should stick to a qualitative systematic review only. And this is a time when probably you can include both. You can include observational studies and the RCTs as well. Do the risk of bias assessment separately using ROBS2 and Robbins-E tool for both of them. There are other ways of making it more refined if you are doing only the systematic review. The individual data of all the studies can be summarized in a summary table and an outcome table, and based on that you can generate some kind of conclusion. So the answer to this is very simple. If you can't do a meta-analysis, and if the Cochrane book says that the minimum number of studies required for a meta-analysis is 2.9, if you have less than 3 studies, you should not do a meta-analysis, even if you have sufficient data. You should stick to a high-quality systematic review only.
Okay. Now, you also have highlighted the need for robust and standardized studies. What specific research questions or study designs would you prioritize to address these gaps in your review?
Let me take this opportunity to mention one core concept, which is called as COS, which is basically it is called as core outcome set. So core outcome set are a group of outcomes which are specific for a particular type of study. For example, if it is a analgesic efficacy, there are certain outcomes which should be present. What happens, I will tell you about our systematic review. In some studies, pain score at 1 hour was available, 3 hour was available, 6 hour was available. Some studies, it was direct 1, 6 and 20. So even though we plan to have analyzed 24 hours specific interval pain outcome, pain score was not reported. It's not that the authors, they don't document it. They probably they note it down, but because they were comparable, they don't report it. And the most difficult part, let me tell you, in this situation is you want certain data and you contact the authors. They don't respond, unfortunately. They think it as a spam. So we don't get it. Basically, there was an article in Regional Anesthesia Pain Medicine. It's a Delphi study where they have mentioned core outcomes set of core outcome sets for regional peripheral nerve blocks. So those particular outcomes should be reported. I mean, the journal, the reviewers, the editor, if they have not reported, it should be asked. either as a supplementary file or as a part of the table. So coming to your question now, what I would say, the robust RCT should be an RCT which has less bias, where medications are comparable. You don't want to compare apple with oranges. For example, opioid with a non-opioid, yes, that is an ideal way of doing it. But the problem happens when tomorrow somebody wants to do a pooled analysis. For example, remifentanil can be compared with sufentanil. Remifentanil can be compared with dexmedetomidine also. It's fine, but using non-opioid analgesic and comparing with opioid, the pain score assessment, probably unless you have nociceptive monitoring, probably we really don't know whether it is only controlling the hemodynamics or it is controlling pain also. So the outcome, post-operative analgesia, probably will be a little difficult to answer in such cases.
Now, my last question to you is for anesthesiologists, what are the key takeaways from your review? So how can they apply your findings in their daily practice? There's a lot of talk about multimodal analgesia in bariatric surgeries, opioid-free analgesia. So does remifentanil have any role?
See, basically opioid-free analgesia, I don't know how ethical it is. So because again, the answer to this is unless you are monitoring nociception, which is not probably very much validated, or rather it is not available everywhere. So unless it's a regional anesthesia technique where you are not using an opioid as an adjuvant, that is probably the only opioid-free anesthesia that you are giving. But otherwise, under general anesthesia, there have been studies. For example, let me quote two studies. One was a total hip arthroplasty where opioid-free versus opioid sparing was used. And basically, postoperative pain was comparable, but 24 hours opioid, they used rescue analgesic as opioid. It was the same in either group. The second study was in anesthesiology 2021, where you compared remifentanil with dexmedetomidine in non-cardiac surgeries. And the study was actually called off because of high incidence of bradycardia in dexmedetomidine. When you try to strictly avoid opioid, probably we are actually doing more harm. So as far as opioid sparing is concerned, probably remifentanil is the best drug because of its short half-life. It doesn't stay with you. It keeps you comfortable, rather stable, pain-free, intraoperatively, and postoperatively you can use whatever multimodal analgesia you want. I would say for bariatric surgeries, probably it is safe. You can add a regional anesthesia technique, and you can add all the other safer drugs like lidocaine, small dose of dexmedetomidine, NSAIDs if it is not contraindicated, for a better perioperative outcome in this group of patients.
Thank you very much, Dr. Abhijit. We would love to again catch you and quiz you more on systematic reviews and meta-analysis. But for now, I wish to thank you so much for joining us on the podcast today. Dr.
The
Rakesh,
pleasure is all mine.
Thank you. Dr. Rakesh, would you want to add to this?
I think the best person to add is Dr. Gayatri today. I can say SRMA encyclopedia, so you can summarize. So only I could say is that IJA will be having a good number of SRMAs in future as well, and good quality of studies. So I again invite all the potential researchers to publish their academic material in Indian Journal of Anesthesia, and we'll try our level best to maintain the timelikeness and maintain the quality. And I also thanks all the readers and all the viewers of Indian Journal of Anesthesia for their whole support in the year 2024. And I humbly request, do continue your support for 2025 also. Do share your good work so that people across the globe can use your research for improving the patient outcome. And IJA will take it forward for spreading it to all the potential readers of IJA so that our patient gets benefit out of it. Back to you, Dr. Gayatri.
Thank you very much, Dr. Rakesh. And thank you to all our listeners for patiently listening to us. I request each and every one of you to go through the Indian Journal of Anesthesia January issue. It is focused on systematic reviews and meta-analysis, like I said when we started. There are a lot of good editorials, narrative reviews, and articles published on the same topic. And as the year goes, we promise we'll get you small bits of information and interesting discussions on research-related topics. Thank you very much for joining us once again. Till the next episode, stay safe and stay curious.